Okay, Assalamu alaikum. Good evening, everyone. It's a real pleasure being with you tonight. And it's such an interesting topic, I believe. I might be biased, of course, being a heart failure cardiologist. And joined with me a dear colleague and a friend, Dr. Ibrahim Jaledan, who's a heart failure and transplant and echocardiography cardiologist at National Guard Jeddah, and uh, the current president of the Saudi Heart Failure Working Group. It carries a lot to my heart as well because of its history. Um, if you all recall, it was founded in 2012 and has been doing a great job, alhamdulillah, with many people working on its progress, and now looking forward to the new era with the leadership of Dr. Ibrahim.
الله يعطيك.
Today, فيك رسالة هيك. Today our topic is interesting. It's something that we have also been talking about for a while. Unfortunately, hasn't picked up a lot of momentum, um, but is very crucial to be reminded of every now and then. I will start by a small announcement and then a touch on guidelines, uh, heart failure management guidelines, specifically heart failure with reduced ejection fraction. Then I'm going to give the floor to Dr. Rajledan to talk about a specific important topic, which is heart rate management in heart failure. So I will share my slides now. Okay. Can you see my slides? So Ibrahim, are my slides moving?
Yes, it's the lipoclinic slide.
Yes.
Yes.
Yes, it's moving now. So, without deep indulging in details, the Saudi Heart Association has been very keen on improving and promoting education um, among all healthcare professionals, specifically cardiac professionals, being physicians, allied health, nurses, technologists, in improving on cardiac care in the kingdom and in the region. Um, the Saudi Heart Association does this through collaboration with many sectors, governmental and private sectors. And one of its strong collaborations have been with Servier for a long time. And during our collaboration, we started something called the Lipo Clinic, where recorded lectures by experts in the field on dyslipidemia guidelines and management have been recorded, and through which healthcare professionals can log in and receive education and CME hours as well for this educational platform. There have been 5 modules: pathophysiology of dyslipidemia and atherosclerosis, guidelines and treatment targets, statins and its combinations, efficacy, a role of non-statin treatment, and barriers of achieving targets in dyslipidemia management. You can scan this code for those who would like to right now or later through the Lipo Clinic. You will sign up and register, and then you will log in. There are other courses, of course, that have been done with Serbia, but the most recent is the Lipo Clinic. You can log in choose the module, and after listening into it, you will have a few questions and CME, up to 6 CME hours required. So again, I hope this is very helpful and beneficial for everyone. And it shows the commitment of both us at Saudi Heart Association and Serbia in increasing the awareness and education in lipid management. Now, moving to, I don't want to be biased and say a more interesting topic because they're all interesting, they're all healthcare, they're all cardiac care and very important. But the topic of the night is heart failure management and specifically personalized heart failure. Yes, our guidelines in general, and as you all know, Alhamdulillah, Sadat has been very active in producing and writing guidelines in many sectors, but heart failure was one of the first and early guidelines that have been written and updated last year. Now, yes, our guidelines are based on studies, based on evidence. Most of the evidence lump sum all patients together, but is it true that um, it's one size fits all? This is the argument of personalized medicine. Um, we, short of knowing which patients will do better with which therapy, usually start what has been approved by the evidence and by the guidelines and tailor according to the patient's needs and responses. A touch on the burden. We all know heart failure is a huge burden. Um, Medically, economically, and outcomes, there are, and this is an underestimation, I'm pretty sure, because we don't have very clear data, but about at least 21 million adults worldwide, and it's a prevalence of 1 to 2% of any population. So maybe in Saudi Arabia, we have at least 500,000 to probably 1 million people with heart failure. And 50% of heart failure patients die within 5 years of diagnosis. And that's worse than many of the cancers that we know of. Economically, it's a huge burden, whether because of the direct or indirect cost of heart failure management, and it costs billions, hundreds of billions of dollars managing heart failure worldwide. Big part of the morbidity of heart failure is because of rehospitalization. It's the number one cause of hospitalization in patients aged above 65 years old. And many of these patients have several comorbidities, and we can see that in our population. Up to 60% of our patients are diabetic, heart failure, and cardiac patients are diabetic, hypertensive, hyperlipidemic, and chronic kidney disease, obesity sometimes. And so it depends a lot, of course, on the type of heart failure, whether it's HFrEF or HFpEF. But many of our patients, as we all know, have at least three comorbidities. Heart failure has been divided into, according to the ejection fraction, to HFrEF, HFpEF, and heart failure with mid-range or mildly reduced, ejection fraction. And each one of them is a topic by itself that needs to be discussed on its own. With heart failure, there is several pathways that have been activated and targeted for therapy. Classically, a long time ago, we discovered the importance of the sympathetic system and the use of beta blockers for that, the renin-angiotensin system and aldosterone system, as well as the natriuretic peptide system. And from this came all the therapies that we are used to and we know about, including the RAS inhibition, aldosterone antagonism, and sacubitril or neprilysin inhibition for that sake. Um, Again, I'm not going to talk a lot about the diagnosis of heart failure because it's a topic by itself, but it's quite important to, at this point at least, to differentiate according to the ejection fraction because many of our evidence-based medicine is targeted to the patients or has shown evidence according to the ejection fraction. HFpEF has always been a difficult category of management. We were more successful in heart failure with reduced ejection fraction, where all these pathways, whether it's the RAS inhibition, neprilysin inhibition, aldosterone antagonism, and um, and beta antagonism has been very successful. Recently, we have been more successful in HFpEF, specifically with the use of SGLT2 inhibitors, and there is more data with aldosterone antagonism, specifically finerenone, with its evidence in patients with HFmEF and HFpEF. So our guidelines have clearly stated that any patient with a reduced ejection fraction, less than 40%, again, many of us might consider those in the mid-range or the mildly reduced, also reduced, but the evidence is not as strong as those with reduced ejection fraction less than 40%, should be on the four pillars of therapy, which includes RAS inhibition, um, specifically ARNI, if intolerant ACE and ARB, a beta blocker, an MRI, mineralocorticoid antagonism, and SGLT2 inhibitor. Very important note is to up titrate to maximally tolerated dose, meaning up to the target dose that has been studied in the trials. That is the dose that proves benefits. And that has been given green. Green means recommended. If the patient remains symptomatic after these, we might consider it might be beneficial to add hydralazine nitrate, use vericiguat or digoxin, according to the patient's condition. But what has a higher level, if the patient is still symptomatic and has a heart rate above 70, is to start evaluating. And this gives the touches on the importance of heart rate in the management of heart failure with reduced ejection fraction, and that's the topic of Dr. Julian next. Now, the controversy was always how should we sequence these medications? Should we start them in conventional sequencing, one after the other, or start two at once, three or four? That is not a very not a finalized topic yet, but most of the evidence is that the sooner you combine them, the better. Many of us, because of the possible side effects, the need of following the blood pressure, creatinine, potassium, might start one or two, and then within 2 to 4 weeks add the second or third and up to the fourth. But it's been agreed upon that as much as possible to get all four started within 4 weeks, and then to up titrate to target doses after that. The sooner you start them, the better. Now, to choose between starting a beta blocker first or angiotensin receptor neprilysin inhibitor first, an SGLT2 inhibitor might depend a lot on the patient situation, on his blood pressure, his heart rate, his creatinine, his status of congestion, on his follow-up. All these things might dictate whether you will start an RNA or an SGLT2. I typically don't like to start beta blockers first because of um, their negative inotropy, which is modest, but in the beginning of a heart failure management, a patient who just, especially if they just came out of a decompensation, beta blockers to me usually comes later. But the bottom line is that the sooner you get them all combined, uh, the better the outcomes of these patients. So, just a take-home message: physicians should focus on prevention of heart failure by focusing on risk factors. Definitely, that's the best approach, of course, with many of our patients being diabetic, hypertensive, ischemic heart disease, and those are the most common causes of heart failure. All efforts should be made to initiate and up-titrate foundational therapy, a personalized patient approach, adjusting GDMT to the patient's hemodynamic profile and kidney function may allow to achieve a more comprehensive therapy. High heart rate is an independent risk factor that should be controlled, and consider all heart failure drugs with an impact in prognosis from the first visit. I will stop here and uh, let the microphone to Dr. Jledan, who will take us through a general talk about heart rate and heart failure with induced restriction. So please, Dr. Jledan.
شكرا دكتور وليد، يعطيك العافية. I will start my lecture. Just gonna share my screen. Okay, so everybody can see my screen. Dr. Walid, thank you for laying the ground for this part of the treatment pathway. As you mentioned, we should start our patient on GDMT or guideline-directed medical therapy as soon as possible with the highest dose possible if there is no significant side effect profile from those medication. Based probably in the STRONG HF trial, we're aiming to achieve those targets by 6 weeks now in our patients. Because as you know, as you mentioned, heart failure journey usually carry a poor prognosis at the end. So we're trying first to tackle the patient as much as we can in stage A heart failure. So the left side of the graph, when they are in the green area, if they are at heart failure risk, diabetic hypertensive, treating those conditions very well, screening for high risk patient. And then once the patient develop heart failure, usually they have an acute decompensation with an acute escalation of care. And they reach an area of stability, as you can see here in the orange, in the first orange part. But then eventually they will progress until they reach an advanced heart failure stage. So our aim, if the patients already slipped between our hand and develop heart failure, is to try to keep them in the baseline or the stable yellow part in the graph as long as possible, utilizing any weapons or medication that we can use as possible. Because we do have significant residual risk. I know ivabradine was something that was developed a long time ago, and now there are multiple medication that carry significant or better actually class of evidence, but still we do have a residual risk that's very huge. So if you look at the empagliflozin trial, for example, which is one of the latest medication that joined the HFrEF quadruple therapy, and you look at the 8 years follow-up for those patients, you can see that with quadruple therapy, 100% on SGLT2 inhibitor, 90% beta blocker, almost 90% RAS inhibition, 70% on MRA, there's still significant evidence of hard cardiac event at the 8-year mark, reaching around 30% of heart failure hospitalization or cardiovascular death. And I just added this slide like 5 minutes before when Dr. Reed was speaking about the residual risk, comparing the atherosclerotic heart disease, residual risk. So the very high risk patient who just had an MI with high risk factors, their risk factors for cardiovascular event in the high risk category is around 7%. Compared to the heart failure ward, if you have a quote unquote stable patient, which I don't think we have a stable patient per se, but maybe like if we can call it in remission or compensated state, the risk of having events in the first year is around 20%. So it's almost triple the residual risk in atherosclerotic vascular disease. And I don't think I will go through the numbers. Dr. Reed already mentioned the high risk mortality in heart failure patient, and especially at the index of hospitalization. So usually the period or the first month post-discharge is usually carry a very high risk for those patients. And this period is critical for the patient because they carry the highest mortality. And usually if they survive the first few months after stabilization, discharging from the hospital, they usually carry a better prognosis. And like Dr. Waleed mentioned about the heart failure physiology, why we're caring much about heart rate. Because if you can see in this graph, once you have a myocardial injury, you have an activation of multiple pathways. One of those pathways are the sympathetic nervous system and also the RAS inhibition. So when we are trying to treat the heart failure, we're trying to treat a lot of those pathways with the medication that we're developing. And one of those is heart rate and inotropy, because more heart rate you have in heart failure patient, you'll have higher chance of having myocardial toxicity. And then by inhibiting the heart rate with beta blocker, usually we achieve a better outcome in heart failure patient with better remodeling. And also, when we look at the heart failure, some of the registries, so this is one of the US registry, one of the, I think it's a Duke University registry, around 700 heart failure patient. When they analyzed them, they found that there is a relationship between elevated heart rate and between worse outcome or 1 year mortality or hospitalization in heart failure patient. And they looked at the cutoff of 70 when the heart rate was more than 70 or less than 70. And they did adjust for other risk factors like BMP, creatinine, age, etc. So heart rate by itself, it seems to be like a marker of the severity of the disease and also one of the risk factors that will lead to more progression of the disease. And also, if you look at the SHIFT trial, so we're going to talk about the SHIFT trial result later on. The SHIFT trial basically was a trial that compared ivabradine versus placebo in heart failure patients who are already on ACE inhibitor, beta blocker, and MRA. So those were the GDMT at that time. And you look only at the placebo arm. So when you analyze only the placebo arm, so people with heart failure who did not receive any medical therapy, only the baseline, including beta blocker, when we divided them into multiple heart rate, we can find that the higher heart rate, the more or the worse those patients did. So obviously, we know that now that there is a relationship between heart rate and worse outcome in heart failure patients. Also, this is a big registry, optimized registry from the state as well. When they looked at the patient who are having LV systolic dysfunction at discharge, we only found that around more than 70%. So 2/3 of the patient almost did not achieve the control or the target heart rate below 70 that we're trying to achieve in the beginning post-discharge. So that put those patients at higher risk profile. And also, if you look at this analysis, this was a combined analysis that was done combining the data from both paradigm trials. So the trial that introduced the sacubitril valsartan was Entresto, as you know it, and alcycrine. Alcycrine is a renin blocking agent that was not successful in the heart failure ward. But eventually, when you look at that, when they analyzed both trial data together, they have more than 10,000 patients, and they divided the patient into quartiles or tertiles. You can see that the lower the heart rate below 63 had the best outcome for those patients with lower cardiovascular death and lower hospitalization. And that's with one of the newer medication that we're using right now, which is the sacubitril valsartan. Also, when we delve more into this analysis that they did at both trial, we can see that when the heart rate was achieved or reduced at a certain level, we have more pronounced evidence of the cardiovascular death reduction or heart failure hospitalization compared to the patient that did not change their heart rate or heart rate increase with the trial ongoing. And also when they looked only at the atmosphere trial, so bear in mind this was a negative trial in terms of the heart failure, heart outcome data, but we found that when they analyzed the patient with the heart rate that was dropped, so around 1,200 patients, we can see that the quality of life of those patients improved with lower BMP, higher score in the KCCQ score that emphasized that those patients felt better. So we know now that the heart rate is a crucial part of our management of heart failure patients. So what we can do to achieve a better heart rate control. So obviously we start with the guideline directed medical therapy, including the gold line, the class 1A medication, which is beta blocker. We do have evidence from the for the carvedilol, metoprolol, succinate, and bisoprolol. Those are the three beta blockers that have the strongest outcome in heart failure patient, with some data suggested nebivolol, but I usually lean toward the three medication that was mentioned clearly in the American guideline as the class 1A, that it will reduce hospitalization and mortality. So beta blocker is the first step that we usually use to introduce heart rate reduction in those patients. But sometimes we do have issues with beta blocker because of difficulty to escalation, because as Dr. Reid mentioned, they have the negative inotropic effect, so sometimes dropping the blood pressure, having difficulty to achieve the target heart rate with higher doses, especially with patient with very poor ejection fraction. So that's what when we can use ivabradine. So ivabradine will produce only a pure heart rate reduction because it's act on reducing the diastolic depolarization slope, so acting on what we call the funny channel in the SA node. So just purely reducing the heart rate without affecting the inotropic function of the heart and without affecting negatively the cardiac output or the stroke volume. And we know that the ivabradine was introduced to the heart failure world by the HFrEF trial. So that was a big trial that compared the ivabradine versus placebo on top of the comprehensive medical therapy that was tried back in 2010. And we can see that the primary endpoint, which is cardiovascular death or hospitalization for worsening heart failure, was reduced by around 18%. And that was statistically significant with a positive p-value. So that's why this was introduced to the guideline, as I'm going to mention later on, and I will mention clearly the indication to use it. And we can see from analysis from the HFrEF trial that was done later on that if ivabradine with beta blocker actually improve the heart rate without affecting much the blood pressure, and that will increase our stroke volume. So that's why our patient felt better usually when they drop the heart rate. Especially if you look at this analysis also as well of the HFrEF trial, we found that patients with the lower heart rate have a higher stroke volume when they were analyzed later on by echocardiography, and that's on top of the baseline medical therapy. So when we kept the same medical therapy for both patients and we just looked at the ivabradine part, we can see the improvement of the stroke volume with the introduction of the ivabradine. And when we look at the HFrEF trial as well analysis, we looked at multiple patients, different blood pressure cutoff. We can see that the benefit still persists with different blood pressure cutoff. So even patients with low blood pressure benefited from adding ivabradine to the standard therapy. So that's because the ivabradine will not affect your blood pressure negatively and will not cause hypotension that sometimes will prevent us from escalating medical therapy for those patients. This is actually a very small trial, but it actually will help us understanding a concept. A lot of people think if we start ivabradine, for example, in some patient, we're gonna affect our ability to start beta blocker or titrate beta blocker. But I don't think that's the case because this is a small trial. That trial was done in around a few number of patients, around 70 or 80 patients, when they started those medication together. And when they started those medication together, they were able actually to achieve a better heart rate when they started carvedilol and ivabradine at the same time. And we were not able to achieve this when they started only the carvedilol alone. So it's just a proof of concept that when we start both medication, we still can achieve a good dose of carvedilol optimization with ivabradine. And if you look at the data from this small trial, as I mentioned, you can see that combining those both medication actually help patient achieving higher dose actually of beta blocker with lower heart rate. Could it be because probably when initiating ivabradine early, sometimes for patient with super high heart rate, low blood pressure, low cardiac output, you're not able to titrate medical therapy. So reducing their heart rate safely first maybe will improve their stroke volume, improve their blood pressure, improve their cardiac function. You're able to optimize medical therapy furthermore, and then you're able to achieve higher dose of beta blocker. That's probably the theory. And if you look at this, is also another small study that was done in Taiwan, when we looked, it's a retrospective analysis for patients who were started on sacubitril valsartan or ivabradine, because they looked at patients who got the prescription done together versus a sequential prescription of sacubitril valsartan and ivabradine. And they can see that those patients who did get the prescription with both medication at the same time got some benefit from cardiovascular death and first heart failure hospitalization. And when they started sequentially, there was no difference between the two groups. It's a small study and retrospective, so I don't think we can draw hard outcome data from here. But I think it gives us an idea that some subset of patients that probably come with a lower blood pressure, higher heart rate, you're not able to achieve a good dose of medical therapy. Adding ivabradine in the beginning probably will aid our patient to achieve the optimal dose of other GDMT as soon as possible. And I don't want to underestimate the role of the other medical therapy, of course, but also I don't want to underestimate the role of ivabradine, because if we look at the trial that was done initially in the 2010 trial, the HFrEF trial, that all cardiovascular death and all death was reduced by around 17, 18%. And it was similar to what we saw in the sacubitril valsartan, and similar in some degree to the DAPA-HF trial, although there was a numerically reduced number in IMPRO reduced, but did not reach statistical significance. So I know that GDMT is class 1A and they are very important, but we need not to forget that there is a medication that produce some similar effect to, on top of ACE inhibitor, beta blocker, and MRA, which used to be the gold line medical therapy before, and that was achieved with adding of the ivabradine. So we need just to keep in mind that this medication still work and still there, and that's why it's in the guideline. And if we look at the analysis also that was done at the HFrEF trial later on, when we look at exclusively at the heart rate of 75, so not the 70, the 75, we can see that the benefit was much stronger. So there was more reduction in cardiovascular mortality and all-cause mortality. So probably aiming for those patients will give you the highest benefit for this medication. So after reviewing this now, we have to look at the data. So this is also was one of the analysis that was done in Canada that looked at multiple large clinical trials, including the foundational therapy. And you can see emphasizing the same thing that Dr. Profarid mentioned, that we have to utilize the medical therapy as much as we can. And you can see in the left side of the graph, the untreated patient with heart failure 1-year mortality was very high. The more medication you add, the lower the mortality drop until you reach the foundational therapy in green, which is the 4-pillar. But also you will have added benefit if you add the sinus node inhibition in those patients, probably in those patients with higher heart rate. So it does have a role in our heart failure population. So what does the guideline say? If you look at the European guideline, you can see that the ivabradine is considered as a class 2A because of the HFrEF trial, but we have a specific criteria. So we consider ivabradine as an add-on. You can see in the first line, there is the 4-pillar of medical therapy. But if your patient is ejection fraction is less than 35 and the patient is in sinus rhythm and the heart rate is above 70, you cannot achieve the target heart rate. So the guideline does not explicitly saying you need to have a heart rate below 70 in one line, but eventually by adding this part in the indication, if you have a patient in your clinic with a heart rate more than 70 and you already optimize your beta blocker, either you achieve the top dose of the beta blocker or you're not able to increase it because of the hypotension, or as we mentioned in some of the trial, you're not able to initiate medical therapy in the beginning and the heart rate is very high in the 90s, you can add the ivabradine. But if you look at the guideline precisely, so you have to titrate your medical therapy. If you are unable to do the beta blocker, then you can add ivabradine, and I'll mention the dose later on. If you look at the American guideline, the ACC/AHA 2022, the same thing. It's a class 2A medication. So for patients with symptomatic NYHA class 2 and 3, stable chronic HFrEF patient with ejection fraction less than 35% who are receiving GDMT, including a beta blocker at maximum tolerated dose, and who are in sinus rhythm with a heart rate more than 70 beats per minute at rest, then we can add ivabradine because it's beneficial to reduce heart failure hospitalization and cardiovascular death, and this is very important point. And also, if we look at the Saudi guideline, ivabradine there is also recommended in the color yellow. So we have in the guideline the color green. It should be, and it may be considered as color yellow. So it's there in the color yellow. So ivabradine should be considered in symptomatic LVEF less than 35% who are in sinus rhythm and resting heart rate more than 70, despite medical therapy that is tolerated. So we can see all the guideline. It is actually one of the highest class of evidence for medication other than the foundational therapy. So it is a strong tool that we can add to our patient. This is the checklist that was distributed here in Saudi Arabia before and it will help to guide you prescribing those medications to the patient. So if you look at your patient, you look at the treatment eligibility, if they are symptomatic, if their ejection fraction less than 35%, their sinus rhythm with a resting heart rate more than 70, on good medical therapy, beta blocker is contraindicated or maximum tolerated dose, and you don't have any clear contraindication like severe hepatic impairment, cardiogenic shock, pregnancy or breastfeeding is not indicated, or combined with other CYP3A4 inhibitors, then you can start by, usually I start with 5 milligram BID. If you have an elderly bradycardic and you are afraid of the bradycardia patient, you can start with a 2.5 milligram BID. Then titrate the dose. Usually I go from 5 to 7.5 BID. After 2 weeks, I usually do an ECG and heart rate to check the heart rate and make sure I'm not going into a problem with bradycardia, QT prolongation, or atrial fibrillation. If you develop atrial fibrillation, obviously we don't have a lot of evidence for ivabradine in those patients. And you do have some patient education about the possible side effect. So in summary, as we mentioned, high heart rate is a risk factor and predictor of cardiovascular death and hospitalization. The guideline suggesting to you by suggesting the ivabradine that you should target a heart rate of HFrEF patient less than 70. And we know from the data that we showed that reducing it to less than 70 will significantly improve your hospitalization and cardiac function, and maybe survival if you reduce it less than 75 for those patients who are not able to achieve those targets with the current medical therapy. And with this, I conclude my lecture.
Thank you very much, Dr. Ibrahim. Very nice, thorough overview of the risk, the relation, and the role of ivabradine. And I would ask people to put in their questions as they like, and we'll go on for discussion. Let me ask you now. This has always been my take on guidelines. We try as much as possible to follow uh, the uh, the evidence and the studies. But as much as possible, we don't want it to be confusing. But if you look at the guidelines for ivabradine or HFrEF in general, we said HFrEF is ejection fraction less than 40%,
Uh,
and the pillars, the 4
35%.
pillars are, and then we go and say, if it's less than 35%, it should be. Now, I understand it's the study, but do you think practically I should wait until it's less than 35% to consider evaporating if I already achieved others and the heart rate is still low?
Yeah, it's a very good point, Profit. And I think you also mentioned before, like using the cutoff for ejection fraction is actually arbitrary, and um, there is a lot of variability in reading. Like if you read an echo today with a 35%, my colleague in the next room can read it as a 40%. And somebody else can read it. There is a plus or minus 5% variability. And I'm not sure if there is going to be significant pathophysiological differences between ejection fraction less than 40 or less than 35. So for me, practically speaking, I treat HFrEF patient with ivabradine, regardless if the ejection fraction less than 40%, if their sinus and heart rate more than 70, I usually use it. And the same thing, the guideline mentioned it to be added as an add-on therapy later on after you optimize your therapy. But sometimes with a lot of patients that I face, especially with newly diagnosed, younger patient, the heart rate is like in the 95, almost 100. Blood pressure is very soft. I know that I'm gonna be not able to achieve those better heart rate earlier than like the 6 week or 8 weeks time that I can use. So I can use a small dose of ivabradine with the beta blocker as combination therapy from the beginning. And we see from some of the smaller trial that this is actually good and did not carry any significant side effect profile. It's not going to drop your blood pressure. Usually patients young, they don't have any conduction disease, probably that can lead to problems. So we do have a guideline, but we do have different patients that we can utilize the medication differently depending on their clinical status.
So I guess my other question for the guidelines as well, why do you think it's a 2A? Um, of course, I wish the company has done more trials, but is it because of lack of competitors, of lack of usually when you get more than one drug competing, you get more studies, you get them a higher level. When it's only one drug and one study, that's why I think it's 2A.
Yeah, exactly. It's a one RCT. The guideline have a clear rule about this. So like the SGLT2 inhibitor, when it was a one RCT, they only were initially class 2A. When the dapagliflozin, for example, arrived, they improved to class 1. To be honest, I don't think there is not such a medication carry the same pathology, like pathophysiological characteristic or the pharmacological characteristic. And also, I'm not sure the company had the intention to repeat what they did before, especially now with the era we're moving like 15 years ahead. A lot of medical
Mhm.
therapy. I know we still have smaller retrospective trial showing that the control heart rate, even with SGLT2 inhibitor and ARNI on board, are going to be beneficial for the patient. But do they need to do another trial? And if it's the trial was, then you're going to drop your level of evidence. So I don't think anybody will do it. Um, we can discuss also digitoxin as a newer medication that can be probably utilized also in similar fashion in patients who are not necessarily uncontrolled in terms of the heart rate, but symptomatic patient. We do have a positive trial right now, probably maybe in AFib patient because we don't have evidence for ivabradine. So we do have multiple tools that we can utilize depending on our patient. And as I mentioned in the beginning, the residual risk is very high. And realistically speaking, we do love to start the GDMT in everyone with higher doses, but the reality is not the same as the guidelines. So we do have to utilize all the options that we can.
Yeah, I was just going to ask you about the Jackson story and how, again, long history, up and down, still to be, maybe with the new data that you're talking about, it might go back to 2A, especially in AFib patients.
Yes, especially so probably it's going to be a digitoxin. I'm not sure if we're going to be able to take the data to the digoxin as well. For me, I think if we're able to achieve the therapeutic level, the narrow window, probably we're going to be okay because that's probably the benefit from the detoxin because it's liver cleared and less renal clearance, so less side effect, less mortality and arrhythmias. But probably it will climb the guideline a little bit. I don't think it's going to stay at class 2B. And actually, we do have evidence from before in patients who are advanced heart failure and withdrawal of digoxin was not good for those patients. Um, and it did have a reduction of heart failure hospitalization in the DISH trial. So it was not like a negative medication, but we kept looking for mortality benefit in HFrEF patients. That's why the digoxin was downgraded, but it did achieve heart failure hospitalization reduction in the beginning. Probably it was also in the era with no other medical therapy. That's probably why. But I think now it's going to climb up a little bit in the ladder again.
Now, the story of HFpEF, why why don't you think ivabradine could work? I know it's not, there's no specific trial, or at least not a big trial that showed it. Do you think it's because it was HFpEF is generally a mix of bags, and some patients actually do worse with lowering heart rate. They need a higher heart rate, and maybe because they had amyloid patients as well, which do the worst with low heart rate. Some of our patients with HFpEF benefit from a lower heart rate as well. Um, Do you think ivabradine could have a role in those patients and deserve a pure study of HFpEF that can help can be helped by ivabradine?
So if we look at the HFpEF by itself, like ejection fraction purely above 50%, probably they're not gonna do much, do well, because we know right now that there is a lot of smaller data that actually they are, if they're not AFib and they're not ischemic, they usually like a little bit higher heart rate. So I don't think it will succeed in those patients specifically. If you look at the HFrEF, so the mildly reduce, it will may play a role in those patients, because we do believe that the pathology behind the heart failure probably is similar to the HFrEF population with the remodeling effect of the heart. So probably suppressing the heart rate and reducing the dual action sympathetic reduction by the beta blocker and reducing the heart rate, including the stroke volume by vabradine, it may help. So having a trial probably with the 40% and above, it could be beneficial for those patients, but purely HFpEF, I'm not sure if anybody gonna do that with the current body of evidence right now we have.
Excellent. I think you added part of this, but can we add beta blocker, ivabradine, and digoxin together? Don't see a
Uh,
reason why not.
Honest, I never tried the three together, like in my practice. I'm not sure if you did. Um, I'm assuming if the heart rate is still high, for example, then you can add the digoxin if the patient is symptomatic. But I think at that time, probably the patient is really advanced and maybe there are other things we can offer. So I'm not sure if I can do the three together. I never tried it before. I'm not sure if you.
I don't think there's a problem. I haven't, to be honest, I haven't used digoxin in a long time. Um, yeah, with some atrial fibrillation patients who are not tolerating others or beta blockers, I might use it. But even now with heart failure and AFib, we don't target very low heart rates. I mean, atrial fibrillation heart failure is a different story, where our target is heart rate of 80s is doing fine. Maybe lowering it too much is not good, even for heart failure with reduced ejection fraction. So I haven't personally used the Johnson for a long time. Nevertheless, I don't see a reason why not. Just make sure that the patient is not in atrial fibrillation, because then evaluating has no value.
Yes, for sure.
Here is a very interesting question about patients with heart failure and nephropathy, whether it's diabetic nephropathy or other some chronic kidney disease. These are very challenging patients to treat. How do you deal with them?
So actually, cardiorenal syndrome is a very big challenge. Probably they are the toughest patient that we treat in the clinic usually. We are lucky now that we have more therapy that will help those patients. Previously, most of our medication did not achieve any renal protection. We may have some stabilization of the renal function with ARNI before, but now with the introduction of SGLT2 inhibitor, actually they are doing much better in terms of preserving the renal outcome and improving the renal outcome. We do have also right now, if we look at HFpEF versus HF moderate use and HFrEF, the finerenone, the non-steroidal MRA, we discussed it multiple times. We do have evidence that those patients benefit from finerenone in terms of their heart failure. When they did the diabetic CKD trial, they did preserve renal function, but when we looked at the fine arts, the heart failure trial, the signal was not as strong and was not there. But when you look at the all analysis of all the data in the fine heart, it was there also as well. So still there is a debate of the role of non-steroidal MRA. Are they gonna benefit the renal failure patients as long as heart failure? I'm not sure. But I think a key thing we have to focus is helping your heart failure patient by optimizing the GDMT, optimizing good volume status is going to be in the long run the best for their kidney. They're going to deteriorate their kidney function anyway with time. So the key message is optimize their heart failure therapy, reach a good volume status, don't shy away from starting therapies. We know that the SGLT2 inhibitor cutoff is around 20 in the guideline in the trials to start. The ARNI was 30 to start. The Finerenone was around 20, 25 to start. So you can start with those GFRs. And technically speaking, right now, hyperkalemia also can be solved with potassium binders, so we don't need to stop the medication. So unless your patient and which we see in the clinic, sometimes those patients, when you start the medication, they shoot the kidney function very high. Those are the patients you usually struggle with, and you have to go with other choices, maybe vasodilator, and avoid the ARNI or the MRA. But we do have a lot of medical therapy right now that can help those patients with heart failure and diabetic nephropathy. And GLP-1, obviously, is now one of the medication that's helped both population.
That is true. There was a question here about anemia and heart failure. That is a big topic, but what causes anemia and heart failure, and how important is it to be managed in patients with heart failure?
So it is very important. We know from registries that around probably 50% of HFpEF, HFmef, moderate use and HFpEF patients suffer from iron deficiency and maybe anemia, maybe not, but they do have multiple risk factors. They do have poor absorption because sometimes of the edema. They do have chronic inflammatory status that, like the CKD patient, will make them anemic. Also, our heart failure population suffer from multiple conditions that make them start anticoagulation, antiplatelets. So they do have slow bleeding sometimes from gastric erosion, ulcers, etc., etc. So it's very important, and it's linked to worst outcome in terms of the morbidity and in heart failure patient. And we do have right now an options the iron in the patient with iron deficiency anemia, which is the ferrous carboxymaltose and the dorsimaltose. We do have multiple trials that we that showed the benefit in those patients, and meta-analysis that also showed the same benefits. So we do treat those patients. We follow them. We look at the ferritin level and TIBC every 6 months. Usually, I screen my patient in the clinic, and if they meet the criteria in the guideline it's clear in the table with the criteria. You can give them IV iron to improve their morbidity. And if you, in the meta-analysis, there is a mortality benefit, but I think the guideline stick to the trials that showed only hospitalization and quality of life. So it is a very important topic, and it will help your patient. We don't only want our patient to live longer. We also want them to have a better quality of life. And I'm not sure if about you, Prof. Farid, but I see a lot of the patient in the clinic when, specifically with iron, when I ask them about that, they feel the improvement pretty fast, actually. Like they feel better in terms of their energy level and their dyspnea when I replace them with the IV iron. So it is something that we really need to look into in our population.
Definitely, and it could be one of the causes of tachycardia as well. So treating it is important. That will help the heart rate in the heart failure patients. Now, as a rule of thumb, these are uh, general people as well. So there could be several causes besides iron deficiency that could cause it. Heart failure by itself is a chronic disease, and you might get decreased production. But make sure as well that many of our patients are elderly, that there is no active bleeding, and they might not need a colonoscopy or endoscopy to rule out other causes of anemia that need to be treated specifically. Um, Many people have asked to have the barcode shown again. Can you see it? So this is the lipo clinic that we have been launching, and it's you can scan the code and register anytime. Um, I think we covered most of the questions and discussions. It was a very fruitful event and very full of knowledge. Heart failure is a big topic. Today we only discussed a small part of it, which is a very interesting part as well. So again, I would like to thank Dr. Ibrahim for his valuable insights and and thoughts, and thank the organizers and thank Sergey for the support. Um, Thank you very much and have a good night.
Thank you, Prof. Walid, and thank you for survey also, and thank you for the participations.
Thank you.